information presented is in no way to be considered as a standard of care, and the content of this podcast is not intended to be a substitute for professional medical advice, diagnosis, or treatment. The information is provided with no guarantee. All content is for informational purposes only and does not constitute providing of medical, legal, or regulatory advice. Good morning. Welcome to this edition of Blue Crew Medicine. I'm joined here today with Cheyenne King, one of our AirCare flight nurses, and Shalata Sharp, who is a forensic nurse with the Special Projects Coordinator for the Mississippi Coalition Against Sexual Assault.
That's correct.
You got it right? Okay.
You did.
Good. So today we're going to talk about strangulation. It's a little bit different topic than we normally go to, but super interesting, especially the stuff I Googled before we had this. So right into it with the definition. So definition of strangulation is a condition in which the blood supply and or airway is reduced or cut off as a result of compression of the blood vessels.
That's correct. Or pressure around the neck.
Pressure around the neck.
Yeah.
So something, again, that's just the generic definition, but it can manifest in different ways. You can be strangled by, I've seen it, log chains or belts or simply hands, any different way.
Right.
A lot of different ways around the world.
Right.
So let's get right into it.
So one of the biggest challenges that I didn't appreciate was that this can be an underwhelming traumatic injury because they're not bruised, there's not this big swelling, they're not hoarse, they're not all the things that we think of when we think of strangulation or somebody having pressure on their airway. But apparently you can have some pretty bad outcomes.
That's correct. So the problem with strangulation, and a lot of the general public will call it choking, and that's their term for it. And choking is obstruction of the airway with a foreign object such as food or some other object. But with strangulation, it's an implication where you've got the vessels, the blood supply that feeds the structures above the neck, but you also could be impeding getting oxygen into the lungs. So people don't realize that when you partially or completely occlude the vessels that feed the structures above the neck, which is the brain, obviously, and the other structures, that there's a high potential for lethality. And you're right, there aren't a lot of outward signs as a result of that. And also, it can be that you prevent the person from getting air in the lungs. So it can be from pressure to the neck. It could be pressure from the chest. If you have someone or something sitting on the chest and the lungs can't expand.
Yeah.
So all of that can be included with strangulation.
And I guess it just didn't, and I don't know about you, Will, it's not something that I appreciated. You get somebody that comes into the emergency room, they tell you usually they use the term choke, just like you said, and you don't see anything. And so you're just like, okay, I mean, I had no idea that it could be bad. So what I want to try to do is, let's go from law enforcement, because we kind of want to talk to them to EMS, to the hospital, to potentially what we would see later, and then to that delayed presentation. So let's just say law enforcement goes, there's a domestic, somebody says they've been choked, probably using that word. You know, what's something that they need to look for, questions they need to ask?
Right. So the first thing is, what do they see? You know, and when I say what do they see, I'm talking about a victim, or, you know, more our term medical is patient. But what does that victim present? Are they holding their neck? Are they acting agitated? Are they acting almost in a psychotic presentation? And kind of consider that this could be a head injury, you know, a hypoxic brain injury. Yeah. So what do you see with those patient populations? You see them kind of coming out of that, and they can be agitated, irritated, grumpy, you know, for lack of the word I'm trying to avoid saying. But they can be all of those presentations. Also, what are they doing? Are they steadying themselves because their balance is off? Are they, you know, holding their neck? Are they rubbing their neck? How does their voice sound? And then what we encourage law enforcement to do is ask about what the victim experienced. You know, what did they experience during the event, which is my term for the strangulation? What were they thinking during that event? What were their sensations during that event? Consider all the senses. And then you want to ask them if they lost consciousness, and also what they remember after that event, asking signs and symptoms as well, or looking for signs and asking about symptoms as well.
So I never even thought about relating it to an anoxic type because I know we both.
Most of our stuff is, it seems like you occlude your carotids or something like that, and you get the lack of blood flow, and they have the stroke-like symptoms afterwards.
Right.
I've had a couple that were anoxic, but it was like truly failed suicide attempts. Usually, I had one several years ago. It was a guy used a 5-gallon bucket and a log chain off a really short tree. Was never going to work for him, but he did make himself anoxic from it, and had the similar kind of. Looking back on it now, after we kind of sit here and talk about it, and
Right.
I'm like, that's strangulation injury. That's what that was.
Exactly.
But I wouldn't even pick up on agitation. That would more be, okay, this just happened to this person. They probably are going to be agitated.
Right.
And then are they going to be honest with law enforcement?
Well, there is that. And I think it really depends on what that relationship looks like with law enforcement and the victim. Obviously, and we go into the academies, and I've learned a lot from going into the investigator academies. In a, let's just say, a domestic violence situation, is you definitely want to separate the parties. And when you can get that victim away, or, you know, and I know that at the scene, you're trying to assess what is victim, what is perpetrator. But if you can separate the two parties, and the person that you suspect may be a victim of strangulation, you want to ask them these questions. One of the things that is kind of neat, and I can send this article out, it's, you know, think about assessing the 10 cranial nerves. And we actually have an article that a nurse created using a stick of gum to assess the cranial nerves. And she, you know, takes the corner of the gum and rubs it along the face for sensation.
Yeah.
You're assessing the smell, the taste, the flexibility of the hands. You know, are they agile? Can they use their hands? Can they hear the gum? So it's a kind of a way of assessing those 10 cranial nerves and the impact on those structures.
Yeah.
But obviously, I can see where law enforcement's like, lady, I don't have time to carry gum and
I was
do
gonna say,
that.
is there a specific brand? Do we need to like keep Big Red in the aircraft now? Is this something?
Stick, if they still make stick in the tinfoil.
They got them.
Yeah.
It's hard to come by.
Yeah, so
I'm saying flight suits going to get kind of sweaty, a little moist, but you know,
Yeah,
It might not smell very good.
yeah.
But
But
if you can just kind of keep that in mind, the article is more of a reference. I think nurses in a controlled, maybe emergency room environment, they might have more time to do that. But we want law enforcement to be aware that you want to be paying attention to everything about this person. And we can provide a flow sheet. And again, I know law enforcement at the scene, they've got 18,000 other things going on, and their safety as well. But if they can just kind of get familiar with some of the signs and symptoms, just that it's kind of repetitive. The more you do, the more comfortable you get with it. But we definitely want them to pay attention. The key questions that we would like for law enforcement to ask is, did you go unconscious or did you almost pass out? And what I like to say to patients and tell nurses to ask patients and EMS and law enforcement is, tell me what your vision was like during this event. Because some people don't say, oh, well, I completely passed out. But they'll say, I saw stars. It was getting
got
darker.
blurry.
Yeah. And you know you're on the edge of being passing out or being unconscious. What about, tell me about your hearing. Because at that verge of becoming unconscious, it kind of gets muffled. Victims have said, like I was underwater. So that can be a good indicator, hey, this person, something really traumatic was happening. Or they said, I remember this, and the next thing I know, I wake up on the floor. So that's important.
Now, does it have to be, the severity isn't always the same as to what happened to them versus the injuries they sustained, right? So
that's correct. Yeah. And just like every other injury that someone receives from a traumatic event, everybody responds differently and everybody heals differently. And I give the illustration of, strangulation impacts so many things. It can also impact the cardiac rhythm because of where we know the electrical conductivity runs for the heart and the vagal nerve. So if you have a person that's walking around with a cardiac arrhythmia and they don't know it, hands-on strangulation can result in an immediate or delayed fatality. That's the theory that we have.
This is kind of going down a rabbit hole, but what if you had one pre-existing, like say it was AFib, or you didn't have one pre-existing? Is that something like, hey, this is new onset AFib that could be, I get it, typically typically anoxic injuries, whether are going to be ventricular arrhythmias, but could it be atrial as well?
It could, yeah. And because we don't have people that run into the medical facility every time.
Right.
We're basing this on what we know about medicine, anatomy and physiology, and theories that we have. If you put pressure or impact that area, what can be an adverse reaction to that or an adverse response to that. So it's theories that we have, but we're starting as we train more on this and we have more people forensically trained and doing better assessments, we're getting more information that are like, yep, that's what we theorized.
You can get better data that you know is
Absolutely.
controlled and better. All right,
Yeah.
look, this is the process that went through it and went straight from that interview process.
Yeah.
So how likely, so law enforcement's there, how likely is the victim to, most of the time, go ahead and seek that medical treatment?
Very rare.
See?
Because they'll downplay it. And
Yeah.
I think the media has a lot to do with that.
Yeah.
If you watch, and I'm not going to call out specific shows, you know what they are.
Mm-hmm.
But if you watch those shows, a victim of strangulation has significant physical signs,
Right.
all of these
Oh, yeah.
injuries that
Yeah.
you can see.
You can
and
see
they
a clear handprint.
Exactly. And
Yeah,
they
that's
die, and law enforcement shows up and, squirts some solution like Windex
Right.
on the body and has an identifier right
Yeah.
away. That's not the case.
Yeah.
So people will downplay it. Also, with perpetrator behavior, this is an escalation in violence. So this is part of domestic violence and what we see in the cycle of violence, the circle of violence. So it's an escalation, the honeymoon phase, and it's just this continual cycle.
Yeah.
So also victims are like, well, I don't want to get this guy in trouble. I
Right.
didn't die, or it wasn't that bad.
Yeah.
What the perpetrator's doing is saying, I can take you closer and closer
Yeah.
to the
Just
point
keep
of
on
death.
pushing it one more little.
Yeah,
every
yeah.
time.
Yeah, which is, so law enforcement, what do they, knowing those questions, knowing how to identify somebody probably needs medical treatment, but what do they have that they can charge somebody with that does this?
So now strangulation is a felony in Mississippi.
is
Previously, and I'm saying previously, I want to say, and don't quote me on this, but it was about 2010, 2012, and in that time frame. Prior to that, it was a misdemeanor. It was part of misdemeanor domestic violence, and now it falls under the aggravated assault and felony. So it is a felony.
So what pushed it over?
The potential for lethality, what
Okay.
we were learning
that
nationally.
delay of, hey, it may be fine right now, and then 2 days later they show up,
Right.
and they are half dead or dead.
The Strangulation Institute that's based out of San Diego, California. Myself, Paula Broom, who at the time was with the Mississippi Attorney General's office, we went there as a team to learn more about this. And I think his name is Stacy. Oh, I'm going to mispronounce his name. But if you go to Strangulation Institute San Diego, all of the staff pop up. But they were learning that they were missing strangulation cases when these victims would turn up as fatalities. And then they would look at the history, and there had been complaints, and it was always a misdemeanor, yet the same crime they were charging as a misdemeanor caused the fatality. So that was the basis for their educational foundation to try to educate more about that. And the International Association of Forensic Nurses, they have really gotten more versed in this and provide a lot of education about strangulation. And of course, it's more towards forensic nurses, but we include that education to pre-hospital care as well.
How many patients or victims do you think we miss?
Probably about 80%,
Which is
I would
crazy.
say. Yeah, just because you don't know what you don't know. And if you're not forensically trained to know how to assess that patient, ask those questions, look for those signs, then you're going to miss it.
Well, and if this is the same person that's been doing this to them, they're going to downplay everything, and I'm sure just say, okay, I'm alive.
Exactly.
So that's good. I'm good with it. I lived through it.
Yeah.
We'll move on.
And they'll, for lack of a better word, they'll be ashamed of some of the symptoms.
All the attention that they're getting from outside of their relationship in the first place.
Or question if anybody's going to believe them.
Right. Exactly. Well, who's going to believe me?
Right. I don't have marks, just like you said. Yeah.
One of the signs we see is incontinence of urine and or stool, rapid onset seizure that is rapidly resolved. And when we we think seizure in the medical community, we think, okay, this is a seizure disorder. You get the aura, you get a sustained seizure, and then a postictal state.
Yeah.
You don't see that in strangulation. And I've got plenty of video, and where you see hands-on, within seconds, the patient's experiencing, or the victim, seizure activity, hands off, and then recovery from the seizure activity.
That's crazy.
And one of the things that victims won't tell us is that they urinated on themselves. That's embarrassing. So that is a specific question that we train pre-hospital providers and hospital providers to ask that question.
I mean, I would have a hard time saying that.
Right.
Maybe I'm medical, so I hope not, but that's not something people want to tell you.
Exactly.
So once EMS gets there, hopefully law enforcement have asked the questions that you talked about. And if you don't mind, we may share. Can we attach?
Mm-hmm. We can add it in the description of the podcast and everything. So we can talk about the flow sheets and then the article you talk about.
Yeah.
I might take that and use that in my everyday practice anyway. But just because I like carrying on. But yeah, we can add everything in there as the flow sheets or whatever.
So we'll add that so they can see. So EMS gets there. Let's say law enforcement has done that. I know that's got to be helpful to EMS, but any change in their vital signs. So beyond what we already talked about, what would EMS kind of look for?
Well, you want EMS to do the same assessment. You want to get the patient away from the scene if you can. You want to ask those questions about what their experiences were and their symptoms they're having.
EMS might understand those answers a little better than law enforcement.
And you want EMS to really look closely at the body. And places that we never think of looking for petechiae is in the ear. Think about where the capillaries are. In the ears, in the mouth, on the lips.
Yeah, I would
mucous
not
membrane
think
tissue.
about that.
Inside the nose. And when you look at the eyes, if I were just looking straight at your eyes, I'm going to see what white is exposed. Well, what about a full assessment of the sclera? Asking the patient to look up, look down, left and right, like you would do a full assessment. And you want to look in the scalp. You want to listen to the heart, put them on the monitor. You want to get an O2 stat. So you want to treat this patient as they had compromised airway, they had compromised circulation to the brain, like you said, an anoxic brain injury, think along those lines. That's what we would like EMS to do.
And that's a way better way to put it.
Yeah. And to tell the patient this is a significant emergency. If you can't make them understand that not only your eyes, your ears, your nose, your mouth, your swallowing, all of that was impacted, your brain was basically starved for a period of time.
Yeah.
To super simplify this down, in my mind, the way everything you've said, I just think of stroke. I think of like, all right, hey, so if I can explain to somebody, well, you were strangled, that could be a stroke. And you just kind of pitch it that way and say, hey, look, I want to make sure you're not having a stroke, and you can explain different kinds of strokes and all kinds of things for the patient. But same thing as far as assessment. If we're sitting there looking for petechiae, just know when you're doing your, getting them to stick their tongue out, make sure they don't have facial droop, all those little things.
Right.
If you say, hey, look, I'm looking for petechiae, you're looking for, in case they did have a sling of clot too, but think more, hey, what are those subtle things that are different? Where they have petechiae showing out? Is there any kind of bruising? Do they have anything where they got hit in their face? Is there any kind of trauma you can see underneath everything? Again, ongoing abuse is one. When I think of strangulation, again, I think of that tiered system of, hey, this is not the first time usually. It's like the second or third.
Yeah.
Or beyond that. And so are there other signs, hey, this person really needs to get out of there. We really need to get them to the hospital. Get, again, even that more detailed assessment than I can do in the back of an ambulance.
Right. Exactly. And another thing that we don't realize is that petechiae on the surface of the skin, fluid petechiae, which a lot of petechiae, looks like a rash.
Yeah.
So if you have someone and their face is a little discolored, it's okay, is this your normal? Let me get a mirror, or you hold up your phone. Is this what your face normally looks like? Now, obviously, if they've been, and this is what I hear, well, what if they've been crying? Yes, if they've been crying, you're going to have that red face, you're going to have the red eyes. But you may have the hoarseness. You want to assess all of that and ask, well, when did you start crying?
Yeah.
So it's a lot of it is timing. And you also, like I said earlier, you want it, what were you experiencing? How did that? And I like open-ended questions. Tell me about what your ears were doing.
Yeah.
I want to circle something back to you with the stroke. So what we know about the structures of the neck, which is, we primarily with strangulation think the jugular veins and the carotid arteries. It's a little bit easier to partially or completely occlude the jugular veins. So if you've got deoxygenated blood putting pressure against those vessels, then you've got this 20, 30 something year old that, let's say 2 or 3 weeks or maybe a month or so later, comes into the ED with hemorrhagic stroke. Why?
Yeah.
Why do we have this happening? Or they come in with ischemic stroke symptoms.
Yeah.
Why do we have this happening? You know, when you let that blood sit there and put pressure against the vessels or sit there and clot, there's going to be implications after that.
Especially if you had, like, again, to me, what spooks me more than anything else is you had something underlying and you didn't know it. So you had some kind of weird venous fistula or subarach, you know, any one of those little things you could pop up and have an aneurysm somewhere.
Right.
Just this one instant, it could throw you over the edge.
Exactly.
Again, it may be something slow like a subdural, and you get a CT scan back. Hey, I've had ongoing headaches for 2 or 3 weeks. I was involved in a domestic incident, and that's all the patient tells you.
Yeah.
Hey, I was involved in something 2 weeks ago, and you get back and you look at this chronic subdural, and you can see where it's like this has been going on for 2 weeks. Like this is something. Hey, it was because of that strangulation injury.
Yeah, exactly. Well, and we've had one of the things that we know long-term effects following victims of strangulation is that victims that have been in a relationship where that was a part of the abuse they get diagnosed with atypical migraine. And I thought, how many people have that atypical migraine where it almost presents like a TIA? Yeah. So you get the migraine, the headache, and then you get the numbness or weakness. Paul and I did a SANE course, sexual assault nurse examiner course in Tupelo. And one of the nurse practitioners came up to us afterwards and she said, I was in a domestic violence marriage. I got out when I was in nursing school. I developed what my doctor called atypical migraines. I blamed it on nurse practitioner school and had never had an MRI done. And we're like, okay, well, you need to go back and have an MRI.
Let's schedule that next week.
Yeah, exactly.
Let everyone get you into imaging.
But all things, even if EMS is not there at the initial, these are all things that if you have this young person with these crazy neuro symptoms that we do not typically see, it's something that they need to think about.
Exactly.
That, and maybe prompt those questions and ask.
Yeah.
I think it is our responsibility to probably push these patients because we've seen enough of them that don't want to tell you anything.
Right.
To push these patients and be like, look, this, you're very young. This is highly unlikely. What's going on.
Right.
Is somebody doing something that we need to know about and can help you with.
And just to add on to that, just like anything in medicine, it's a trend, right? So like that initial, you build that rapport with the patient on the side of the road, on the side of whatever highway you're on today. And you say, hey, look, I really care about you. I want to get you seen about. If you can relay when you're transitioning to an ER, local ER, level 1 trauma center, doesn't matter. Hey, this is what I found. They say, hey, well, now they're starting to develop, picking hoarseness out of a bucket, but develop this symptom. Or, hey, petechiae are now more pronounced. They were initially on the bottom of their lip, now they're on the top. And this, you start to see those, okay, hey, look, this is truly a strangulation injury. The documentation needs to be appropriate from a legal side of the street. But, hey, I also need to make sure nothing's happened to this patient. Let's make sure we scan them now, and then we're going to scan them again in 8 hours and make sure nothing's changed. Like that kind of trending the patient to say, hey, look, we're going to watch out for you because it's not an acute benign thing when you get strangled.
Right.
Yeah.
And it's recommended that this patient has what we call the 23-hour OBS admit.
Yeah.
We don't, and I say that for insurance purposes because we don't want them to have a full hospital admit.
Right.
But that is the recommendation, that this patient is monitored like a head injury. And we would do that with a concussion. We're going to keep that patient in, observe them, do with the neurovascular checks. That's what's recommended for our strangulation patients. And a CTA to look at that blood supply.
So, random question. So, we're back on the scene. EMS is there. Is it worth them measuring? Because every time we think about swelling in our careers, measure, right?
Exactly. It is worth it to measure.
Okay.
And I reference an article that I read, and if I can find it, I'll send it to you. But it was a law enforcement officer that had done really aggressive education with his frontline patrol. And there was a situation, and the victim, she was seen at the scene emergently, and this investigator said, frontline patrol said, if they won't come in and get seen, could you at least measure their neck? And her neck was measured at the scene. She refused EMS transport. The investigator reached back out, got her to come in 2 or 3 days later. He measured her neck, and it was larger. So there was swelling, and she didn't even realize it. But she said, quote unquote, everything hurts.
Right.
So, and being, I'm assuming being in a domestic violence situation, it makes your whole body hurt regardless of the physical blows. And, but yeah, he captured that her neck was significantly larger because of edema, that from the scene. So that'd be awesome if we could get that measurement.
Yeah, that would be, I mean, something we can think about doing when we get those odd cases. But so I'm thinking in my head, if you're going to see strangulation, you're probably usually going to see them punching, that kind of thing. Can you just see strangulation? Is it always strangulation with sexual assault or physical or?
It isn't. It isn't always strangulation with sexual assault. It can be. Okay. It isn't always strangulation with domestic violence, but it can be, and it can be just isolated strangulation as that part of control. Keeping in mind that sexual assault, domestic violence, those are crimes of power and control. When you have a perpetrator saying, "I'm going to control you by these means."
Yeah.
So if the perpetrator realizes, excuse me, that I don't leave marks when I put hands on the other person's neck, or I sit on their chest, or I put them in a chokehold, but when I hit them, I leave marks. Then what are you going to do? You know?
I didn't think about that. Yeah, that's, I don't know. It's sad. And it's sad that this is something we're just now, I mean, I've been a nurse for 20 years, and this is something I would have never thought to pick up on any of it unless they were bruised. They were swollen. They had passed out, those kinds of things. So even, some kids that I've seen come in, trying to strangle themselves.
Right.
Not for purposes of killing themselves, but, you see that, and I think we take that a little more seriously because you found them with something around their neck, versus someone who says, I've been strangled. I don't think we take it as serious.
Or the choking game, or chokeholds, or anything that, makes what used to be TikTok, or YouTube, now it's TikTok again.
Right.
Anything that gets a lot of hits, we're going to keep replicating it for that. We want that attention. So our young people, that's what we want to pay attention to and ask those questions. Yeah. It could be that this is what they're seeing in that media format.
Yes.
And doing
which is
that.
Sad.
Yeah. I'm glad you brought that up. I remember that coming through PZR a couple of years ago, and it was a trend. Yeah, we're going to see how long you can last in a chokehold.
Right.
And these kids, and like 2 or 3 of them, like, hey, you just bought yourself a pick, you stay. Like something, you're acting off. You got a GCS 13, 14, something's not chilling. You're not coming right back to baseline. Yeah. I don't think it ended up being anything long-term effects, but it was one of those, all right, well, it's...
But do we know what the long... Yeah.
Right.
Exactly. We don't know. I have one of the videos I show in a training is a method of the choking game. And there's some females that are up against a brick wall, and these males, and there's a group of kids around, but the males will get the females to take some deep breaths and then lean into their chest. There's no hands on the neck. Yeah. They're just leaning into the chest. One of the girls, her eyes roll back. She actively seizes as she's falling down, and she hits the ground, continues to seize for maybe a second or two, and then stops. The video cuts off, and when it was on YouTube, you could hear somebody say, "Oh my goodness, she," and use the term for urinated on herself. And it was really scary because to me, it was like she came so close to becoming an instant fatality. Yeah. The same amount of pressure, or it looked like the timing, both girls had the same amount of pressure. The other girl didn't have those experiences.
Yeah. Which makes you wonder, did she have something pre-existing that she didn't even know about?
Right.
So what's the trigger? So they get to the emergency room. What's the trigger to admit them for that observation?
That they say that was their experience. If they say that, hey, this is, I was in this situation and I was choked. We want to clarify. Tell me what that means to you. Right. Tell me what your experiences were. And we're getting the patient describing the hands, pressure to the neck. And you want to ask for those, what they experience, sensations, signs, symptoms. But if they say that I was choked or that was their experience, that ought to qualify them. Because we don't know how it's going to present later. Yeah. I go back, and of course, me from way back in the ER. I worked in the ER for 18 years, and I wonder how many patients we absolutely missed. Yes. But I got called when we had the on-call program to a sexual assault patient. She came in EMS from a hotel, so she wasn't familiar with our area. And her memory was, there was a knock at the door. My next memory is I'm waking up on the floor, and my genitalia was hurting. Yeah. So that was all that was presented. Yeah. But The triage nurse that night called me when they got her in, and it took about 30 to 40 minutes for me to get there. And when we walked in the door together, the triage nurse had put her in a room and not gone back. And when we went back in the room together, the triage nurse said, well, she didn't look like that when I put her in here. And in that time frame, she had so much petechiae, her face looked purple.
Wow.
And that's the orientation picture I have of her. If you didn't look up close at that image, she just looks like her face is purple.
Yeah.
Like almost like a really bad rosacea type presentation. And it was just flora petechiae. It was everywhere. And it was all, and what you'll see with petechiae is it's above where the pressure is.
Okay.
So there was almost like a demarcation of her neck.
Pretty standard line. The ones I've seen, it's like almost a fine line.
Yeah.
Hey, this is exactly where it starts and this is where it goes up.
Exactly. But it's a great case study I present because it's in her hair, it's in her ears. And places you wouldn't think to look. In her nose. She had a subconjunctival hemorrhage, which is the smear of blood in the sclera of the eye, which I had a patient once describe that she didn't get medical care, but she said it looked like somebody took a red magic marker and colored my eye.
Yep.
And I thought that's a great description.
Yeah.
And something that non-medical. So, our law enforcement that, they may be like, what y'all do is gross.
Yeah.
So I don't want to know medical stuff. Does it look like a magic marker?
Right. Yeah, that's a good way to describe
Or
it.
does everything look normal? You shine a, say, hey, look, can you read this for me? Can you read it normal? Does the words look fine?
Yeah.
Blurry? Are they colored a little bit different? What color is that to you?
You see two of them?
Yeah.
Yeah, exactly.
So is there any special like CAT scans or x-rays or anything that...
Yeah, you want to do a CTA because you want to look at those vessels.
And neck and brain?
Yeah, well, it's the neck, mainly the neck. And so you want to do that. It's funny, a lot of hospitals will do C-spine x-rays.
Yep.
Well, that's a bony prominence. It's pretty hard. That's not going to show a whole lot.
Yeah.
If we could get colorized MRI emergently, and of course, that's my unicorn goal here. But if we could get that, that would be awesome and probably show. I forget what state did a study, and they said, they picked up a lot of findings doing emergent colorized MRI, and that state, the hospital went, no, we're not paying for that. No. So it went nowhere after the study.
It's too expensive. What are you talking about?
It's hard enough to get it on brachial plexus injury that everybody is concerned. All right, this is it. And I'm sitting here going, man, I'm with her 100%, but
there's not going to happen.
Nobody will go with that.
In my world of unicorns and rainbows, that's what we're going to do. But we'll take what we can get.
So what are the typical injuries that come from that? The typical, to the trachea, to those neck structures that you're going to see? Typically,
we see vessel, obstruction. So, or we see vessel injury. So we see the petechiae. We see, if we see findings at all. Primarily what we mainly see are symptoms that the patient experienced is an interruption in the vision. Like you were saying, that's a great example. Can you read this and how does it look? And then going forward, how's your vision afterwards?
Yeah.
How long did it take it to recover? Is it going back and forth? What about your hearing? Now do you have ringing in the ears? You used to not have ringing in the ears. Are your hearing less in one ear than the other? Something along those lines. What about the sensation on your face? Does one side tingle a little? Is it numb? Does your mouth work equally?
Yeah.
Is it, like it used to when you swallow? Do you now feel like, okay, I'm kind of gagging and choking and I used to not? My tongue used to work better. When we see, airway for trachea injuries, if we see sub-Q emphysema, that's a horrible sign. That patient, the only time I've ever seen it was in a fatality or the patient became a fatality, but that can be a late sign. One of the nurses at Rush, now I'm going to call her name Elizabeth, she had a strangulation patient that had an esophageal tear. Didn't realize it. She had gotten her medical providers to do the CTs, and they picked it up on CT. She was pregnant. And so they admitted her, but she ended up losing the pregnancy. That's another thing that can happen when you interrupt the blood supply. Yeah. You interrupt the blood supply to the baby.
Stress on the fetus every day of the week.
Yeah, exactly. So this patient, if they're pregnant, they're at a higher risk for losing that pregnancy too.
And esophageal, those are not readily identified.
No,
those
no.
can go on for a little while.
Exactly.
Without
exactly.
anybody knowing what's going on.
And this was not, and probably if this patient had not come in, she would have had some discomfort,
Yep.
and never really, it was a small tear, but it was still a tear nonetheless.
Yeah.
And when you say she's pregnant, the first thing I think of is esophageal tear, pregnancy. This is going to perf. This is not going to go bad when she actually does deliver. If
Right.
she gets that
Yeah.
far, if she gets preeclamptic and seizes,
Yeah.
esophageal tear just went wide open. I mean,
Yeah.
all the horror
Septic
stories in
from
my
that
head go
stuff.
like, this is ugly.
So, and you're thinking like forensics, the potential for lethality. And that's why we have changed how we look at strangulation now.
Makes perfect sense.
I know. And so, what of the people that come forward and say this is what's going on, how many of them are immediate versus that delayed, and it just kind of comes out in that delayed?
We really don't know because
Okay.
there's no way to capture that
Yeah.
as far as our literature and the research. But what we see presenting to the hospital is kind of interesting. We see it they'll come in acutely.
Yeah.
Delayed, they're going to come in for something else.
Yeah, and that's, selfishly, that's kind of what I want to learn about for sure. All of this is great, but, we're going to pick them up on the helicopter when things have gone way south.
Right.
So what would lead us to, other than, they're very young, this is odd to have a stroke, that one might trigger me now, but what else would I not think of that I might go pick them up because they're that septic or they're that, they do have a tracheal tear.
Right. Well, it goes back to, I call it intake nursing or triage nursing, is the safety screening.
Yeah.
What is their safety like in their environment? That's a big indicator of whether or not they've been a victim of strangulation.
Yeah.
And like you said, people aren't very, forthcoming with,
Yeah.
I've been strangled or I've been choked. They'll tell you about physically being, or they'll downplay it. They're like, well, our arguments are bad and they
Right.
escalate a little bit, or, COVID, we've been out of work and,
We're
right
in the
now.
same house for 2 years. Yeah.
Yeah, exactly.
I know.
We've got a
Yeah.
bunch of little kids. You know what I'm
Yeah.
talking about. And so they will downplay that, but have to ask those really important questions, specific questions about safety. Has anyone ever put their hands on their neck or made you feel like you couldn't catch a deep breath, or put pressure on your neck or chest so that you passed out or almost passed out? Because victims of strangulation
Yeah.
downplay that.
Yeah.
So until we start asking those specific safety questions, we are going to miss it.
Yeah.
Do you feel safe in your house? Yes, I did not get hit by the tornadoes last week, so I was safe.
Right.
You've got to narrow it down to that interpersonal
Yeah.
relationship and what that looks like to that individual. And I'm going to throw this out there too, because I feel like we're using our pronouns a lot. She is victim, he is perpetrator. And our males or
Yeah.
people that identify as males, they can absolutely be victims of strangulation and interpersonal violence.
I
as
feel
well.
like they would be less likely
Probably
to
so.
come and be honest,
Yeah.
or even call 911 from the get-go
Right.
versus coming and being honest about what led them to the emergency room.
Exactly. And, a female can put a male in a chokehold. A female can put hands on the neck. All of
Yeah.
that can happen. Another thing, you were talking about what to look for at the scene. Defensive injuries, they can be on the victim, because if there's something on the neck, then the victim is going to try to get that off.
Oh, yeah, I didn't
and-
think about that.
Yeah, so
they're-
you may see scratches
Yeah.
on the victim, and you want to look at their fingernails.
Yeah.
Okay, tell me how you got these scratches on
Yeah.
your neck. You want to look underneath the chin. You also, for law enforcement, look at the other person in the household,
Mm-hmm.
and do you see scratches on their arms, on their face? Do you see bite marks on their arms?
Yeah.
Because those are what we call defensive injuries, and we can see defensive injuries on the victim.
Yeah, I never thought about that, because if something is around my neck, I'm going to be sitting here pulling
Right.
at it and trying
Right.
to get it off.
And it's instinctively to tilt that chin down.
It is.
And so you want to especially look underneath that chin.
Yeah, I didn't think about that. So it's kind of sad. As long as I've been in nursing, there's no telling how many that I've just missed.
Oh yeah, me too. And something that I know that you and I really didn't talk about ahead of time is we're seeing that we're recognizing this more in pediatric abuse and child abuse.
Oh.
Because a child presenting to a medical facility or an emergency room, sudden onset of asthma that we don't really have a medical reason for asthma, coughing up, sore throat, and all the structures inside. We don't see, huge tonsils or strep, a rash that can also be petechiae that we've just said, oh, that's just a generalized reaction or rash. So we're missing that.
I was going to say URI with a rash automatically to me. I'm like, hey, is there something else going on here? This is this doesn't add up.
Yeah, because the user's definitely not going to tell you, and the child may not see that as abnormal.
Right.
If that's all they've known.
That's all they've known. Yeah.
That's normal. So it's not something that's they're going to come forward with and think it's a big deal to tell you.
Or children, and I'm quoting a case study, not my own. Sadly, I can tell you that I do not have a patient that I knew was a pediatric strangulation because I didn't recognize it. But a peer in Colorado uses a case study, and some of the language that the children would say were, as part of the punishment, he puts his hands on my neck or his arm on my neck, and then I go to sleep really fast.
Oh.
And the child's eyes to the point of passing out.
And that's normal. So that's not.
Exactly. That's part of the punishment.
So you said, new onset asthma.
Yeah. I mean, when you've got this sudden, for no reason, you've got this asthma attack, this spontaneous asthma attack. Why are we having this wheezing? When you
hard to catch your breath at rapid rate. They're trying to catch back from the hypoxic episode.
And I'm just looking at the pediatric patients that we came in and went, looks like a sudden asthma attack.
Exactly.
And we're like, now looking back, we're like, wow, was that a pediatric strangulation presentation?
Yeah, because we're thinking straight. I mean, it walks, talks, and looks like asthma. So, And
I know EDs are so busy, especially peds ED right now, because you're seeing everything and, everything's opening up. So we're getting more social. But I can just remember when I took the pediatric SANE course and Dr. Bob Block, who was a former chair of the Academy of Pediatrics or the Fellowship of Pediatrics, what instilled in me was every pediatric patient that presents to an emergency department, they need to be completely undressed and they need a complete head to toe assessment. And you need to be looking, not, they said they come in with a sore throat, get them undressed, take a look at them. And we don't do that.
We don't.
Yeah. Or get them in, get them out. But that's what we're missing.
Yeah, we don't. I've worked with one physician that did that. Dr. Stoddard, I love him. But everybody had to be naked.
Yeah.
And he did a true head to toe. It did not matter.
Yeah.
But I just haven't even, so it's mind blowing. I know my eyes will definitely open more to things, when I see them that never was before. You just accept, okay, this is a young person that's had a stroke. Like, we really don't know why, but this is sad that it happened, but okay, let's treat it. But if you don't ask those questions, you're potentially sending that person back home.
Exactly.
And now they have had a stroke. Now they can't take care of themselves. And you're sending them right back.
Yeah. And patients with disabilities, they are more vulnerable to being victimized. And pregnant patients are more vulnerable to being victimized, all the stress that goes along with that. So if you've got EMS, frontline patrol, law enforcement, and that is the patient, this person already has a disability. And when I say disability, I'm not just talking about physical, I'm talking about cognitive, mental disability. Yeah. If they're pregnant, they're at very high risk during that time frame. There's infants in the house, or there's children in the house with special needs. All of these are big triggers, and those patients or the people in those populations are more at risk.
Yeah. So I really just feel like, we need to ask the questions from the get-go, but it's going to start with law enforcement, and then EMS, and then, hopefully getting emergency rooms educated where you keep them in for that observation.
Right.
You get that CTA.
Yeah.
And then most of the time when we're going to see them, they're going to be that delayed, that they're really going downhill, but putting together those puzzle pieces where, okay, this is odd.
Yeah.
Because, pediatrics with asthma attacks, that would be a big one we would go to.
Yeah.
And I would have never even considered.
Yeah. Do they have a history of asthma?
Sudden onset 10-year-old boy does not,
right.
To me, is like, all right, okay, yeah, it's possible to have sudden onset, but something's fishy.
Yeah.
I'm already thinking off the top of my head, where do they get? Usually my thing is like, did they huff something? Did they try
that's
some
my
kind of
thinking
drug?
too.
Yeah.
Those are all the because
Yeah.
those usual suspects. But
Yeah.
at the same time, hey, well, he was wrestling his buddy, and all of a sudden he's now has a asthma attack. Wrestling his buddy, did his buddy put him in a chokehold?
Right, exactly.
I mean,
that's
those
kinda,
little, yeah. How do we go with it?
yeah, that's where you want to getting the kid away from the parent. Tell me when you get in trouble, what does punishment look like in your household? Tell me about that, and ask that open-ended question so that they can tell you in their own words. Like the little
Yeah.
kid that said, "Daddy puts his arm around me and then I go to sleep real fast." That's that's a great history right there.
That's crazy. It's crazy.
Well, thank you for coming today.
Thank
This
you
is
for having
awesome.
me. Yeah.
Is there anything we missed? I know I picked your brain, but
I mean, I can't think of anything. I think as far as what I would call emergent response or, pre-hospital response, especially, we're available for education. I'm not the only person that trains on this. So if, I can find somebody if I'm not available. And also we want, for law enforcement especially, we can help you by educating the prosecutors. And when I say we, talking about forensic nurses, there's several of us around. Let us help you with that case. Let us come in and do education. Call us. As I say, my phone is available 24/7. If I'm doing things like a podcast, then I may not answer it immediately.
Right.
But as soon as the recording's over, I'll definitely respond and see what I can do to help you out. But the big thing is ask those questions. Don't be scared to ask the questions.
Yeah.
And when you pull, and there have been times where, for lack of a better word, the victim was arrested because that was the one that was so excited, making the most noise, so agitated. And one deputy that this is years and years and years ago, he got into a little bit of trouble with his leadership. And when he was talking to me about it, and he goes, "I feel really bad. I put her in jail." And I'm like, "Wait, you did keep her safe for the weekend."
there you go.
I was going to say, she was screaming for help, but you did keep her out of that place for a minute. Like, I mean,
I was like, so if that helps you sleep better at night, she was safe for the weekend.
That's true.
But it's not always what you think when you show up.
Yeah.
Separate them, ask those questions. As I tell law enforcement, way better how to do your job than I'll ever do it. And I'm not worthy.
I'm definitely not. But it's not, I could see where people would not just be forthcoming with everything.
No.
Because it's embarrassing.
It is embarrassing. And they don't realize how severe it is.
They don't.
How dangerous it is.
Yeah. I mean, and to me, I know you said it to me, we were talking the other day, I would just be happy that I lived.
Yeah.
So I would feel like I was on the other end of whatever happened to me and everything was going to be fine.
Yeah. And if this is an escalation and you've seen this escalation, you may go, well, he's going to calm down.
Yeah.
He's or she's going to calm down. This will be fine in a couple of hours. I don't want to go anywhere. This is okay.
Yeah.
Yeah.
And I can see that.
Yeah.
well, thank you for coming today. I learned a lot.
Oh, good.
So it's a pretty awesome experience. I'm glad we get to share it with everybody else too.
Good. Thank you. Thank you for having me. I appreciate it.
This has been a presentation of Blue Crew Medicine.